So, ladies and gentlemen, we have already seen nice surgery, disc excision in Rouen, colorectal resection in Strasbourg. So let's stay a while and think about the outcomes of our nice surgery. And this presentation is based on two articles, original articles. You find them, you can find them on your USB flash drive. So I will rush on several slides because you have a detailed answer on your flash drive. So to accurately evaluate the outcomes of colorectal surgery, we have to try to answer three questions. All colorectal nodules responsible for all digestive complaints in women with rectal endometriosis. Second question, does nodule removal we perform may solve all digestive complaints of our patients? And the first, is rectal surgery we perform responsible for new postoperative digestive complaints which do not exist preoperatively? The first question, the answer is into the recent paper I published in American Journal of Gynecology and Obstetrics. And please believe me that quick answer is the responsibility of rectal nodules for patients' digestive complaints is not mandatory. As digestive symptoms are usually present during the menses, however, the rectal nodules do not disappear during the intermenstrual period. And also, the same digestive symptoms are present in women with endometriosis but without an actual rectal involvement. The second question, we must be aware that systematic removal of rectal nodule does not inevitably solve patients' digestive complaints. And it is very interesting to look at several series, but to look only at the tables and the results without reading the conclusions of the authors. So I started by looking at papers published by friends of me from France. You can see the series of Bichat Hospital in Paris, where all the patients underwent colorectal resection, and you can see that the symptoms were unchanged or impaired in the case of trouble, abnormal bowel movements, constipation, and tenesmus, unchanged and even impaired. Also, in the series of Tenon Hospital in Paris, the rate of same, unchanged, or impaired symptoms is 45% for constipation, 22% for defecation pain, and 59% for tenesmus in women who underwent a colorectal resection to present with relief symptoms. And also, I recently published a paper in Fertility and Sterility, and I evaluated using the only standardized gastrointestinal questionnaire. I evaluated the postoperative symptoms in women undergoing rectal surgery by various techniques, but whose follow-up was superior to 1 year, and the mean follow-up was about 30 months. And as you can see, a majority of them present abnormal values for the questionnaire, for the quality of life questionnaire, and for CAS constipation score. However, as the effect of the surgery on all the pains was satisfactory, they are satisfied by the surgery and by the results. And 9 out of 10 would recommend the surgery to a friend. The third question, may our surgery be responsible for new postoperative digestive complaints? The answer is yes. And I also start with my own series. And I observed that in women managed by colorectal resection, the rate of postoperative severe constipation, unpleasant constipation, is high, above 20%. However, if we try to understand the mechanism of the complication, it's very complicated because this constipation is multifactorial. We found rectal denervation, we also found stenosis of colorectal anastomosis, colorectal intussusception, and transit constipation, meaning that it is very difficult to completely avoid this constipation as the mechanism is multifactorial. I also tried retrospectively to compare outcomes in women with colorectal resection versus women with disc excision or shaving with conservative surgery. And I observed that women managed by colorectal resection are likely to present higher rate of constipation and increased number of daily bowel movements. However, as the analysis was retrospective, I cannot avoid the bias of the inclusion of more severe patients in the arm of colorectal resection. That's why I changed the design. And I performed a retrospective study in intention to treat, meaning I compared two different periods of time. The first period of time where I strongly believe that the colorectal resection is the best way to treat the patients. And the second period of time where I tried to conserve the rectum whenever possible. The first consequences of this change was that the rate of colorectal resection dropped more than threefold, from 67% to 20%, even though the main characteristic of nodule and woman during the two periods was quite similar. And this is very interesting to emphasize, that using the standardized gastrointestinal questionnaire, each time I relieve a statistically significant difference, this difference was invariably favorable to the conservative group. Meaning that if we try to conserve the rectum, we can expect better functional outcome in our patients. And you can see that some items which are improved in the conservative group is unsuccessful evacuatory attempts, failing incomplete evacuation, abdominal pain, time taken to evacuate, difficulty to evacuate causing a painful evacuation effort, and hard stool consistency. Also, the total value of the gastrointestinal quality of life index is improved in conservative arm. It means that attempting rectal conservation whenever it is possible would lead to less unfavorable functional outcomes than performing systematic colorectal resection. However, this does not mean that women managed by colorectal resection are not improved. It means only that the question is whether or not we can further improve their outcome by conserving the rectum. And if you remove the rectum, you have some consequences that must be known. The first is that you take a risk of rectal denervation. Why? Because you have to section the mesocolon, but as my fellow said a few minutes ago, you always have to cut the mesocolon much longer than the segment you remove, because you have to pull out the rectum, the colon. That's why you take the risk of rectal denervation, the rectum you conserve. The second consequence is the stenosis of the colorectal anastomosis. And this frequency seems to be higher than in surgery for over pathology or over disease, probably because of the pelvis inflammation. The third consequence is that you remove the rectal reservoir. It means that women will undergo more frequent bowel movements. And the last complication, the last effect of the removal of rectal reserve is a delayed complication, unknown complication. You have to know that the rectal reservoir play a role in dumping the high intracolic pressure. And when you remove the rectum, this high intracolic pressure impacts on the anus. And you can observe several years after risk of fecal incontinence and urgency. All the four effects of the colorectal resection may be avoided if you perform a disc excision, because you conserve the mesorectum. And in Rouen, we used to perform disc excision in low rectal nodule, high rectal nodule, using the circular stapler you saw on Monday, but also the contour transstar stapler destined to mid and low rectal nodule. which allows to remove piece as large as 8 centimeters. But to bring new arguments to this exciting debate, I started 2 years ago the first randomized control trial comparing colorectal resection to conservative surgery in women with large rectal involvement up over 2 centimeters. The aim, the main outcome is the digestive function 2 years after the surgery. The inclusion criteria are so restrictive, meaning that we included only women with rectal nodule up to 15 centimeters from the anus, with a rectal involvement exceeding 2 centimeters and exceeding the rectal muscularis. However, the width of the involvement must be inferior to 50% in order to perform a correct nodulectomy. And we estimated that we need 60 patients, and now, this day, all the 60 patients are enrolled. And the surgery you saw on Monday, there was the 58 patient. The 59th is next Friday, and the last, the October 7th. It means that within 2 years, I can present the definitive results of this trial. However, we can have a look at results, immediate complications in 50 patients whose follow-up exceeds 3 months. And you have to know that during 24 months, I managed 109 patients with rectal endometriosis. 50 of them were not eligible because the nodule was either inferior to 2 centimeters or circumferential. 50 of our patients were enrolled, and 9 patients were eligible but not enrolled because they live abroad, foreign patients. Meaning that the inclusion criteria concerns about 54% of rectal endometriosis managed in Rouen, but this rectal endometriosis are between the most severe. Due to the randomization, the patient's characteristics are comparable between the two groups. And you can see that the largest diameter of the rectal involved, mean largest diameter, is 35 millimeters in each group. And the height of the lowest rectal nodule removed is 8 to 9 centimeters. The stenosis revealed by virtual colonoscopy concern 80 versus 68% of patients. What did you do? We perform colorectal resection in the colorectal resection arm, and we perform conservative surgery in 92% of women randomized in conservative surgery group. When we remove a disc excision, when we perform a disc excision, the mean diameter of the disc was as large as 5 centimeters, large disc. And when we perform a colorectal resection, the length of the segment was 9 centimeters. So we took care not to resect too much. We also performed vaginal resection in 88 versus 72% of cases, and the stomia was used in 56 versus 72% of cases. It is very important to emphasize that when we decided to conserve the rectum, we did it in 92% of cases. In 10 cases, we performed only shaving, and we were very satisfied by the result. In 7 patients, we completed the shaving by transanal disc excision using contour transstar stapler. There were low and mid-rectal nodules. And in 5 cases, we used the end-to-end anastomosis stapler you saw Monday. And in only 1 case, we performed a transvaginal disc excision. Immediate postoperative complication. We observed that the immediate complication were quite similar between the two groups, except the stenosis of the colorectal anastomosis or rectal site of the surgery. 4 cases in the colorectal resection group, 0 in the other group. And then we estimated the immediate complication using the Clavien classification of complication. I don't know if you know it. The grade 1 or small complication, wound infection, or bladder catheterization, similar. The grade 2 complication where we have to give medication like antibiotics is quite similar. Grade 3A. 3A, there are complications requiring an endoscopy or surgery without general anesthesia. We had 3 complications related to the rectal surgery in the colorectal resection group and 0 in the conservative group. Complication Clavien 3B, they are most severe because they require new surgery under general anesthesia. We recorded 4 in the colorectal resection arm and 1 in the rectal nodule excision arm. Meaning that if you have a look of all complications related to the rectal surgery only, we had 7 complications in the colorectal resection arm and only 1 in the conservative surgery arm. However, 3 complications occurred in the same patient. And as we have to compare patients and not number of complications, the differences is only limit tends to be significant, 0.008. In conclusion, the rectal conservative surgery is feasible even though the nodule is large. If you have adequate tools, meaning if you can do a shaving, deep shaving, satisfactory deep shaving, and if you dispose of transanal stapler able to remove large patch. The rate of complication is high. We recorded all the complications. This is a grant founded by a health ministry, French health ministry. I received about 150,000 euros, and all the complications were recorded. When we record all the complications, the rate is high, 27% of cases, even though not all complications are severe. And there is a tendency toward less immediate complications related to the conservative surgery. However, I give an appointment within 2 years to analyze the main outcome, the postoperative digestive function. Conclusion of the presentation is that the colorectal endometriotic nodules are not responsible for all digestive complaints. Their removal do not solve all digestive complaints. Far from more, when you perform a rectal surgery, you must be aware that you can induce new postoperative digestive complaints, and that the conservative surgery must be taken into account because it may decrease the risk of several postoperative complications, and instead routinely perform a unique procedure suitable for all patients. We ought to take a moment to think about what type of surgery in each woman, depending on the parity, depending on the age, of the risk of recurrence. What women do not need radical colorectal surgery, and what women should exclusively benefit for medical therapy because medical therapy relieves enough and the risk of recurrence is very, very low. Thank you very much. And here, this is the final picture of the woman I managed last Monday. Thank you very much.